That's the sound of the coffee pouring. Welcome to the Doctor's Brew. I'm your host, Dr. Abdulaziz Al-Khayyab, and having coffee with us today is Dr. Hasan Behbehani. Welcome, welcome.
Thank you very much.
So, for our listeners and viewers out there, today's topic of discussion is going to be about a medical specialty that is often consulted frequently by trainee doctors like myself. I will let you all guess the specialty we are going to talk about by saying a quick story. I had a clinical rotation during medical school with this specialty, and the first thing that they said to me during the rotation is, "We don't know how to put cannulas better than you, so stop consulting us about it." So, for those of you who haven't figured it out by now, of course, I am talking about anesthesiology. Today, we are going to focus on the role of anesthesiology, and more specifically, pain management, and the role it plays in the life of a junior doctor. With me to discuss this, of course, is Dr. Hasan Behbehani, who is a consultant anesthetist specialized in pain management. And he studied in Ireland, Galloway, right, med school,
Yeah.
and specialized in Canada. And you worked in Ontario and Toronto, right?
Both the same thing. So fake London,
Fake
Ontario,
London. Okay.
which is in Ontario, and then that's where I did my anesthesia residency, and then I did a 2-year pain residency in Toronto.
Okay, awesome.
Yeah.
Cool.
And previously, as you said, Galway in Ireland. Yeah.
Right. And you're currently working as a consultant physician
Well, considered consultant, but really it's a specialist.
Right.
As a specialist in anesthesiology and pain, based in Jabr Hospital. I have a clinic once a day in Amiri.
Oh, okay.
And the afternoon private, but the public is in the morning. Yeah.
Awesome. Now, before we get into the medical stuff, this is the doctor's brew. Brew part. Coffee. Today's coffee we are drinking from Earth Roastery, right?
Okay, yeah.
Tell us, what are your thoughts on the coffee?
It's good. It's really good, actually. Yeah. I don't drink coffee.
There we go. The first sin to be committed on the doctor's brew.
Yes, yeah. But it's actually good. I've been drinking it since coming here. So yeah.
Okay. So one last sip of coffee, one last sip of water, and let's dive in. So, big question right at the start.
Okay.
Why should anybody choose anesthesia?
Okay, good question. Well, I'll tell you why did I choose anesthesia. When I graduated and came back to Kuwait from Ireland, I felt kind of lost. I didn't do a long elective in Galway in anesthesia. And when I came back, medicine for me was too boring. Like long rounds, long clinics.
Very long rounds.
Yes, very long rounds. Correct. Sorry, insurance. And then the surgery, they were long and for me too complicated.
Right.
So and I didn't do a lot because I was a junior, just hold a scalpel and everything. So, and then I feel like it always starts with a mentor. So I met someone, anesthesiologist, who I started talking and then did an elective.
Right.
And that's how I got into anesthesia. However, in broader terms, after being in anesthesia now, I can say that anesthesia is, so the word anesthesia itself is just the intentional practice of putting someone unconscious. But anesthesia is a much bigger
The
specialty.
intentional practice of putting someone unconscious.
But anesthesia is it's a small term for a much bigger, wider specialty.
Okay.
So in anesthesia, as a resident or a doctor, as a consultant, you deal first with so many different specialties. So you work with different colleagues from surgeons, general surgeons, vascular, pediatrics, obs and gynae, even medicine. So that's a huge bonus. Number two, you deal with different type of patients. You deal with pediatric, neonates, adults, and you deal with them at different stages of their lives, different moments, stressful moments, all the way from a new birth to, if you specialize in pain, to comfort measures, for example. So like completely wide varieties. It's a mix of science, applied physiology, pharmacology. That's a common thing that we say, and a lot of skill. So intubation, lines, regional, which is a huge advancement in anesthesia now.
Right.
So it's a nice balance for me, at least. It's not too much into the hand skills, and not too much just science. It's applied science, and you see your results immediately. So when a different specialty is treating the blood pressure over 2 months or 1 month, I'm treating the blood pressure immediately and seeing the effect. It's so rewarding. And even when you put in an epidural for a pregnant lady and she gets comfortable immediately, it's just I've done this over the residency over 5 years. Every time I did it, it felt good.
Okay.
So it didn't change.
So you still get the satisfaction now?
Yes, exactly.
So you don't get you haven't got bored.
And I do pain now, so I still get satisfaction. And it's very rewarding, even if it's short-lived. The other thing is anesthesia is a gateway to other specialties. So when you come into anesthesia, just like any other specialty, there's regional anesthesia. Like when you go to gastro, there's IBD, advanced colonoscopy. Anesthesia is regional and stuff like that, but also there's the opportunity to be an intensivist, so go into critical care and manage critical patients, and also pain,
right?
And have your own clinic, and you have
managing
more of continuity of care with patients. Yeah, and speaking of like different personalities, anesthesia, we do care about patients a lot, and a lot of people think that we're not social. To the contrary, you have to be very social in a very short period of time.
Okay.
And you have to, like a patient who's coming very anxious with stage 3 cancer, for example, coming for a big surgery, you have to build a rapport with this patient in the morning of the surgery. So that's a skill and something I enjoy doing on a daily basis. And when you go home, you still think about your patients, but you don't have that continuity of, like the chronicity of dealing with some of the issues that other specialties have. So it's some people think that it was a bonus if you're not into anesthesia.
So it's short-lived.
It's short-lived, but it's intense.
No, but that's a great thing.
Yeah,
you know?
yeah. To me, it is. Yeah,
like you mentioned, the quick reward.
Exactly.
Yeah. I'll tell you my fear with anesthesia, though.
Tell me.
So I'm currently studying for my exams, and I'm doing U-World at the moment. And
good luck with it.
Thank you. Yeah. Every time one of those questions pops up about physiology, so like patient is in a surgery, and how do you play with this setting, or I don't know what, or what do they need infused, and they give me physiological parameters. It just becomes a foreign language. It becomes hieroglyphics.
Yeah.
All melts.
Sure.
So is that? Do you think is anesthesia that bad?
It's actually it's very simplified. So there's a lot of physiology in it for sure, 100%, and it takes a while to get used to it. But the good thing is you don't have to be a mathematical genius to go to anesthesia.
That was my question.
I do my 5 + 5 on a phone. So I still do my percentages like that. But anesthesia does teach you some skills to overcome that.
Right.
And it slowly builds in. The more you use the medication, the more you use it, it becomes just as if you're driving home. You don't need to remember the direction anymore. You just know how to go home. The more you read, the more you do, you'll get there. It's not as hard as people think.
Do you think for like juniors like myself who are, we're thinking, right, so what specialty do we want to go in? And we look back at, hit the mic there. We look back at how med school was for us. And I think with anesthesia, there's this heavy connection to pre-med because, again, that was when the bulk of physiology was for us. Do you think that someone who is not necessarily, because there's a lot, myself included, I was a much better clinical student than preclinical student. Would you say that someone who was not as strong preclinically should be like you, stay away from anesthesia?
No, I honestly don't think so.
Really?
Yeah, because I was an average student, and I'm not sure. I didn't have a I didn't have a pre-med, but we didn't go to the hospitals until 4th year.
Yeah, that's what I mean.
So same thing. Didn't matter. It's applied physiology. You have to understand the basics, but when you realize how much it makes sense, I'll just give you a quick example, like the flow equation.
Right.
and what affects flow, like in a just a small IV, in terms of the density of the solution, the length of the needle, the gauge. That alone just makes you, oh wow, like that small bit of science can save my patient's life, and can give him as much as 300 ml of blood in 1 minute, right? Just by applying an equation.
Right.
So it's not boring science, it's fun science. Yeah.
Awesome.
Yeah. Most of the time. Unless you're studying for the exam.
Right.
Yeah, then it's boring science.
And with all honesty, please.
Yes.
Can you guys cannulate better than us?
Probably yes.
There we go. Okay.
But some of the nurses can calculate better than me. Like yeah. Like there's these IV nurses. I've been doing it for a while. Yeah. And plus we have a rescue plan. We can always put a central line. So
central lines.
Yeah.
Always.
Yeah.
Now
I'm not advocating for that.
Okay. So what does an average day for you on the ward, like in the hospital life? What does that look like?
On the ward or in the operating room?
You know what? Sorry, that clicked for me for a second, because I was thinking in the mind of kind of internal medicine, life on the ward. So what is life in the hospital for you on the week to week?
Yeah.
What's your life like?
So for interns, just to be clear, we don't have interns in anesthesia, obviously, but they can do electives with us, and I highly encourage them to do that. Okay. So for me as a staff anesthesiologist, I would read up on my patient the day before. Okay. If I'm in the operating room and not doing my pain clinic or pain procedures, know what procedure is about to happen, what's the indication, and what's the past medical history of the patient. Go in prepared. I would go in early morning. In Kuwait, we have a meeting to discuss all the cases.
Morning meeting,
yeah, morning meeting. So I would go in the OR, open the lights, make sure all the drugs are ready, draw on the drugs to put the patient to sleep, and the drugs that I need to help me with the hemodynamics. And so basically, just in a nutshell, I would prepare the operating room for the patient who has already been optimized and prepared for the surgery. And I would prepare my surgeon, have the quick communication either before, if it's a big case, or during the day, about the position, what's needed, and so on. Once that's done, in the OR, I would go and speak to the patient, confirm all the information is accurate, comfort the patient, make sure the patient's not superly anxious.
So you communicate with the patient?
Oh yeah, okay. I would spend, and I always encourage the residents to do that. So I would talk to the patient, take a quick history. If the patient is, I think, we'll take a joke or two, I would do that. If not, then I would just keep it professional.
I like that. I like that very much.
Yeah, and comfort them. I tell them exactly what's going to happen today. Okay. That we are moving, even as simple as we're moving to the operating room. We're placing you in a different bed, a cold environment. We are going to put leads on you, because they feel like a robot. Like they go in and everyone's spreading their hands, applying the blood pressure, and they're like, "Oh, what's happening?" And sometimes they feel demonized. Like,
true.
Why is this all happening?
But do you think anything needs to be left out?
No, nothing should be left out. It should be blunt and accurate with empathy. But you shouldn't hide anything. The patient is an adult or can make decisions, and they've already consented for the surgery. Yeah. So yeah, we explained everything. If I'm going to put lines, where is the patient going to go post-operatively? They're going to go to the floor or they're going to go to the ICU. Confirm that they're okay with having blood if needed. Take informed consent of any procedures I'm about to do. Tell them how am I going to manage the pain intraoperatively or post-operatively,
right? And
if I'm going to put up an epidural, thoracic epidural, or any other nerve blocks. And yeah, I would do that. Start my case. Do a pause with the surgeon, make sure everything is okay. Do the case. So it's a lot of people say this boring yet true. It's like a takeoff, landing, and takeoff, cruising, and landing.
Yeah.
So and then the case goes on. Usually, hopefully, smoothly. If not, then we're ready to. We're monitoring every heartbeat, literally every heartbeat, in the OR. And then if we need to, we would intervene, and then we wake up the patient. And sometimes it's not always a steep patient.
Right.
A lot of time we just do a block. Yeah.
Have you struggled communication-wise with patients? Because I've consented patients for anesthesia before.
Oh, okay.
Yeah, yeah.
Really? Okay.
Well, sorry. No, I haven't consented. I started the consent process because that was kind of part of getting the consent for the procedure.
Yes, gotcha. Yeah.
And I mean, generally, I don't. There is a mistrust in Kuwait. We know that there's a mistrust in Kuwait for doctors and for medicine. I blame WhatsApp for 90% of it. Have you faced this issue?
There's a misunderstanding and lack of awareness, or as you said, some messages that get out, the wrong messages. So there is always in a small minority that happens, and I remember that especially when I was an intern, because if they don't see the consultant early enough, they're worried. They're like, what's happening? Are you just going to practice on me and stuff like that?
Yeah.
So it's important to try to send the message out clearly, and answer any questions. And so that's how I would try to overcome it. Doesn't always work. If it doesn't work, I would inform my senior for advice and so on. But there's some mistrust, especially the vision of the country is not clear. So a lot of people who are sick get sent abroad and so on.
That's true, yeah.
So people are like, why do I need to be sent abroad? Is it because the healthcare system is not good? To the contrary, I'm sure we have some deficiencies.
Yeah, of course.
But
naturally, like any other
just
place.
like any other place, it's a learning curve. So
that's interesting that the messaging about the country, to the country people, it's unclear, because it's true. We send all of our graduates go to Canada, to the States, and even in Kuwait, and even our boards are being slowly getting recognized,
accredited by the Canadians and others. And so we're trying to have the foundation.
Yeah,
it's just I think mixed signals are being sent.
Right.
And I don't blame the public sometimes for the mistrust. But I think with some education and programs like these,
hopefully
podcasts like these, the message will get sent out.
That's what I just wanted to ask is how do we counteract, because we have misinformation going on WhatsApp and just from conversation, which again is natural. This is not necessarily an abnormal thing. How do we counter?
I think we should just continue the conversation, continue talking, continue to educate. Don't dismiss the patients. Don't dismiss their concerns. If it was me, I would be anxious as well. So
I mean, getting put to sleep it's scary.
It's kind of scary.
Actually, okay, this is kind of a weird question.
No, have I?
No, I have a weird question for you. This is a really weird question. Psychologically,
yes,
was it not crazy for you to kind of just see, like, I'm basically taking this human being, I don't want to say you're making them dead, but you know what I mean?
I'm putting them in a coma. And
there we go. Yes.
Like literally in a coma.
I remember, like, for me, the first time in med school, like in the anatomy lab, the first time I remember it was, I leaned back and I just felt a cadaver's foot on me. And my heart skipped a beat and I went, oh wait, this is the only place in the world where this is okay. This is normal.
Yes.
Psychologically, was that an experience for you to kind of
we would like with colleagues, we always get abused for we are the doctors with the drugs, with the good stuff, whatever they say. We don't generally abuse them, but it's actually a huge responsibility, taking someone and putting them into literally a coma. A controlled coma. It's a huge responsibility. That's why anesthesia has always been associated with safety. So the practice of anesthesia is always safety has always been the number one thing in anesthesia. That's why we're always compared to pilots, because we always have a set of protocols to follow whenever something doesn't go well.
Right.
And we depend a lot on machines, ventilators. So yes, it is kind of psychologically scary or weird, but all physicians have a responsibility for safety, but it's just a different way. Surgeons cuts people open, literally, and I'm taking a small different part, but it just adds more weight and makes you thankful that someone trusted you to do that.
Yeah, of course. Now circling back to, we talked about kind of what it looks like for you in the hospital.
Yes.
Now, clinic-wise, what do your clinics look like?
Okay, so in general, in anesthesiology, most of the time is spent in the operating room.
Mm-hmm.
However, anesthesia, I would say, does not start in the operating room. It starts
Okay.
outside of the operating room in the pre-op clinic, or the
Right.
in other countries they call the pre-admission clinic.
Right.
So this is where you optimize your patients for the upcoming surgery.
Right.
Make sure everything is accurate.
Right.
In my practice, because I have a pain degree, I also have a pain clinic.
Right.
Where I see different kind of patients with pain, chronic post-surgical pain, cancer pain, neuropathic pain, and like lumbar disc pain and peripheral joints.
Mm-hmm.
So I do that on Tuesdays in Jabr and Wednesdays Behbehabi, and it's totally different dynamic.
Mm.
Because as an anesthesiologist, you usually see the patient once,
Right.
maybe see him in the OR, unless it's a recurrent surgery.
Mm.
This is more chronicity. You see the patient regularly, you
Chronic
give him
pain
medication,
management, yeah.
you might do a procedure.
Mm.
So that's a pain clinic.
Actually, talking about pain clinics, I never truly appreciated the role of pain management until my father, God rest his soul, he had cancer,
Yes,
and
I know.
the pain. I think he visited you.
Someone asked me, but he was with also another good pain physician.
Right.
Continue. Sorry.
Yeah. Sorry. It's just that was when I truly understood the role of pain management.
We shared a very similar story.
Mm-hmm.
So my dad was diagnosed with metastatic cancer during my last year of anesthesia residency.
So very similar stories, right? Yes.
Yeah, and
okay.
I saw how much the pain, and that year I was applying to the pain management,
right,
to the pain residency program,
Mm-hmm.
and I got accepted actually at his last 2 weeks or last 4 weeks, and it was very happy. But anyway, I saw how much the pain management changed his behavior, his attitude with us, and how happy he was of the outcome. So despite all the anxiety, depression that comes with it, and the suffering, but that changed my perspective completely. Initially, I just wanted to do the pain residency program because I wanted to do procedures.
Right.
But now I'm more interested in cancer pain.
Do you think that your experience with your dad impacted?
100%.
Okay.
100%. Yeah, just changed my whole perspective and just showed me how much we can, how much change we can do.
Yeah.
And especially in this country.
Right.
Where we have a severe lack of all specialties, not just pain. But and remember when I talked about a rewarding feeling?
Yeah.
It is rewarding, but there's nothing that can, like the patient getting better is and like suddenly able to walk, able to eat, and able to go home.
Yeah.
And just able to go home, not have IVs is just priceless.
Like it's for me. I remember I forgot which consultant, but he told me, he says, opioids are the revolutionized cancer treatment. And that was something that I never clicked. I was like, I thought he was going to say chemotherapy. No. Pain management.
Yeah. I think everything is important, but pain is underestimated in cancer management, for sure.
Definitely. And the effect on the quality of life is amazing.
And they get to spend the last important months,
comfortable.
Much more comfortable. Yeah, exactly.
But one thing that my dad, one issue my dad had with pain management wise was there was a psychological element of he just hated taking so many drugs.
Of course, yeah. Like this happens even with the chronic condition, like patients with hypertension, diabetes, or getting older. They just hate the fact they're taking a lot of drugs. And with cancer patients, the side effects of opioids, the nausea, the vomiting, the interaction, the hallucinations, delusions. So I don't blame them. It's hard. It's very hard. So that's why we have advances in cancer pain management. We have now something called morphine pumps, where you put a much smaller dose.
Oh, it's a smaller dose.
Yeah, it's a smaller dose, but the effect is much bigger because it's directly on where it needs to go in the CSF. So cool. The action will be much bigger with a much smaller dose, less side effects.
Okay.
They could have other means, for example, of pain management, a nerve block, for example. So we try to reduce the resilience on medications as much as possible, and that's why there's a multimodal approach.
Okay.
I'm sure that when we were juniors, like the WHO ladder.
Yeah.
That's why you have to try to try to not escalate quickly unless needed, obviously.
Right.
So Panadol and other medications first.
And what do you think about? I once heard that. I forgot which. Again, a lot of doctors in my life who've given me advice. So if I forget, I apologize. But someone told me that regular paracetamol or acetaminophen, when taken at dose at a regular schedule, is an extremely effective pain relief.
That's actually very good. We say around the clock. So it's a very simple medication. The side effects are very rare.
Yeah.
And the interactions almost never happen.
Yeah.
Unless patient has obviously end-stage renal failure, then you have to be careful. And you have to be careful about the dose. But multimodal approach starts with medication like acetaminophen. So around the clock, I've seen a lot of people when I round on acute pain service, patients, they're not around the clock.
Right.
They wait for the patient to ask for the medication, which is a kind of not the correct practice.
Yeah.
In acute pain, it should be around the clock, usually in most instances, and it doesn't have to always be IV. So in Kuwait, we have the luxury of having IV acetaminophen.
Yeah.
So it's actually, if the patient can swallow and everything, maybe we think about going oral. Like,
do you think it's in terms of from a pain perspective, is there any difference for acetaminophen or paracetamol? IV versus oral?
I've actually, good question, because I've just recently searched this like a month ago or so.
Cool.
The difference is not huge compared to the cost. The cost is huge. So usually oral is more than enough.
Okay, interesting.
Especially post-operatively when the patient can tolerate oral meds. And oral medication generally lasts in the body longer than IV medication.
Okay.
So an IV medication, you give an IV medication, you get the pain, which was here, goes down quickly, but then comes back. With oral medication, usually that curve is more, depending how often you give it, obviously.
Do you think, though, that there's a placebo effect sort of with patients?
I think definitely there's a placebo effect.
Very cool.
When they see the ampule like hanging, I see that often. Because I see a lot of patients with sometimes advanced cancer pain, where you expect them to have a lot of pain, and they... when they see the Pervigan, IV acetaminophen. That's
one of the first things I learned in trainee year. Pervigan is acetaminophen.
And they're happy. And of course, you have to believe the patient. But there's definitely, in pain, there's a lot of placebo effects.
Right.
And because pain is associated with a lot of psychological manifestations as well.
Right,
so it's normal. Yeah.
Like I remember for me, I played on the, also in terms of translation.
That was hard.
I'd say in that, I'd say this is I'd say Perfugan is a musekkin.
Yes.
And I felt like musekkin I don't know if I'm wrong here, but for me, when someone says musekkin, it's much stronger than if in English, when you say, oh, this is IV paracetamol.
Yes, exactly. This is going to take the pain away. That's what you're saying.
And the second I say that term, they just go, oh, okay, relax.
I'm going to get better now. Yeah.
But if I told them, hak habitin Panadol.
Yes, like, is that what you're going to give me?
Yeah, exactly. Now, you touched upon the psychological effect of pain. And I know that pain, at least this is what they taught us for me in Manchester, was there's the physical side of pain, which is that, they're feeling pain and whatever, but also there's a psychological interpretation of pain, which is a whole other thing.
So pain is subjective. So it's a subjective feeling. Pain is what the patient says it is. Yeah. So it's important to respect that and obviously continue taking a thorough assessment.
Right.
But the psychology is an essential part of pain management. It was part of everyone's residency when they did pain.
Really?
Yeah, I did a 2 month, rotation in pain. In psychology, psychiatry, and a 2 month in addiction, something like that.
Interesting.
Yeah. And the whole exam was full of questions, and my actual practice.
Right. So you can understand the psychology behind the pain and help manage it.
We refer patients to them, and they refer patients to us.
Well, that's actually, I was wondering that. Do we do that in Kuwait?
We do that in Kuwait. The only issue is that, and this is everywhere in the world, it's very expensive to have a interdisciplinary practice.
Really? So I didn't factor that in.
Yeah, so the difference between multidisciplinary and interdisciplinary is where everyone together are managing the same patient.
Right.
Well, multidisciplinary is when you refer to like you work together, but you're referring them. So what happens in general is they get lost in the system. So you all go see the psychiatrist and then come back to me.
Okay.
Instead of us communicating directly about this patient. So it happens in Kuwait. We're trying. Not every hospital has a psychiatrist.
Yeah.
Not every hospital has a pain physician. So sometimes they have to go to different hospitals. But I try to, whenever I have a patient, the first, during the feedback, the first 10 minutes or 5 minutes, I try to spend it on, if I have time, I'll try to do my best, is pain education. A lot of patients say, do you think that I'm just feeling the pain is in my head? I would say, no, the pain is not just in your head. You actually have physical pain, but where does everything go at the end of the day? It goes to your brain. Yeah. So taking care of your brain is an essential part of taking care of your pain.
Do you think that pain is also cultural?
Different cultures actually have different expectations of what pain is. So in the US, for example, when they finish an orthopedic surgery or whatever, they are usually easily prescribing opioids.
Right.
And in some other countries, developing countries, they might go home with NSAIDs, non-steroidal.
Really?
Yes. Yeah. Germany, I think, which is of developed countries, in knee replacement sometimes they don't give strong opioids.
Wow.
And Asian countries as well, I think even in Kuwait, the reliance on opioids is much less compared to the Western society. Yeah.
Really?
So,
that's interesting.
So I'm sure there's a bit of culture. I did not investigate that thoroughly to not make assumptions. But yeah.
It's because a colleague of mine on the wards told me that that someone in his unit or consultant, or I'm not sure, was saying how when, for example, Persian patients, when a Persian patient tells you they have chest pain, that means that it is a massive MI. Intervene because they tolerate pain well.
Some people tolerate pain well. Yeah. I guess that could be possibly true.
Interesting. I'm sure there's been research done on this. I'm like certain. I should look into it. Now, we mentioned addiction, and I think a big thing that for us juniors that we struggle with, especially with pain, will be, of course, sickle cell anemia. So if you can kind of give us first a background of what sickle cell anemia, the management of it, the approach in Kuwait is like.
Okay, so I'm just want to highlight one point. I'm glad you said addiction when you said sickle cell. Yeah. Because they're two very different things. Yeah. So, and a lot of times we assume that the sickle cell patient is addicted, but that's not the correct thing. Yeah. A lot of them are actually in pain and require medication. Some of them do end up getting physical dependence, although if they were managed well initially, that risk is much less than when poorly managed and labeled as addicted. Yeah. So in general, I wasn't here a long time ago, but the management is shifting now. And we have a committee from the Ministry of Health. Really? From a hematologist, pain specialist, internist, pediatrics, to try to come up with a plan. Because obviously sickle cell, like I have, in the last 2 years, I've seen more sickle cell patients than I've seen in all my practice in Canada. Really? Yes. It's prevalent in Kuwait more so. Of course, because of, we have the culture reasons in marriages and everything. People get more consanguineous marriages. You get more risk of sickle cell. So we're trying to come up with a plan. And a protocol has been established by the Ministry of Health. I encourage every junior or senior doctor to inquire about that. Yeah. So in general, what happens is that the patient with sickle cell crisis, acute pain crisis, who comes into the hospital has to manage within the hour. With a multimodal approach, and if need be, a narcotic-based IV dosing initially at weight-based. Right. And once that is done in the ward, and it's just not a single dose, like every 4 hours, for example, 10 milligram of morphine, for example, maximum, every 4 hours. And if need be, and patient is still in a lot of pain, the old protocol used to say consult anesthesia. Dr. Abdulrahman Faris is the I'm named Doprik here, but anyway, he's the head of the anesthesia department in Amiri. Said that's lacking, so he instructed us to come up with a different plan or a further plan. So what we did is check the updates, and we included the patient-controlled analgesia, which is a PCA, where the patient can give his self-medication. So if he exceeds that amount, then we could consult anesthesia for a PCA.
Right.
Patient-controlled analgesia. Hopefully that will be implemented on all the hospital, and it will help the patients. The key in sickle cell management is to recognize it early and manage it well to avoid the chronicity of the disease.
Now, I'm sure also in your clinic you must also come across drug-seeking behavior.
I do, of course. Yeah.
So what would you advise for juniors, for us, especially with sickle cell patients, to differentiate between drug-seeking behavior versus, actual pain crisis, or usually it's a gray area of both?
Yeah, so it's a very thin line.
Yeah.
To try and come up with reasons why the patient is in pain.
Yeah.
So we always assess pain not just for some reason. For instances, sometimes you think, oh, the patient is not in pain because he's not tachycardic or not hypertensive. Not necessarily true.
Yeah.
When we treat pain, the main reason we treat pain is to improve the function. So functionality of the patient is better. It's not just a number.
Yeah.
What's your pain? 10 out of 10, but you're doing everything you want in your life. I take that.
You're fine. Yeah.
But if your pain is 0 out of 1 out of 10, but you're not moving out of bed, that's bad.
Right.
So in terms of, it's a very thin line of deciding who's seeking and what. In the chronic pain clinic, we can do urine drug screen, opiate safe prescribing, don't give prescription for more than like a week, dispensing or a month. So these are the ways. In the floor, in the acute setting, ideally, if the patient is in pain, we should manage the pain. And the old practice of giving, for example, I'll say it bluntly, of normal saline flush, that's not acceptable anymore. Yeah.
Right.
And just because the patient, I think, is seeking. You know what I mean? Yeah.
Right. Yeah. And okay, so in terms of us juniors, is there anything in terms of stepping up management? Who do you think should be stepping up pain-wise? Because I'm thinking on call, it's 1 a.m., 2 a.m. Patient is already on a regular opioid regimen. Okay. And they are in pain. And you know how, you'll know how when they get in pain, just the screaming, it appeals to you on a human level.
Of course, I've seen it.
So who should do this step up, do you think?
So ideally there should be a pain specialist in the hospital.
Okay.
Because not all anesthesiologists are experienced pain specialists.
Yeah.
If that doesn't exist, then I think most hospitals will rely on anesthesia.
Okay. And so that's an indication for us to get anesthesia involved?
I would say yes.
Okay.
I would say most of the time yes.
So it's not something that, for example, junior doctors should be handling or deciding upon?
The junior doctor should assess thoroughly, make sure they've scanned all of the causes, they've checked that there is no other internal cause. Right. They've checked with hematology, if you're talking about sickle cell or anything else. Yeah. And they've checked anything else. If that has happened and they've discussed the case with their senior and they're still unable to manage the pain and they're scared of increasing the dosages, then I think there's no harm in consulting a pain physician ideally or anesthesia.
Now another situation that junior doctors often face is post-op.
Yes.
Post-op pain management. What's your advice for us to be aware of? Like, what's something that should be in the forefront of a junior's mind when they're going and see their patient post-op in pain?
Okay, so the first thing is you have to understand what surgery did the patient have.
Okay.
Does this pain make sense? So, did they have an open midline laparotomy, midline incision? Was it a laparoscopic surgery? So because even laparoscopic surgery can be painful. They can have shoulder pain, distension, whatever. Is the pain an alarming sign of something else happening, like a perforated viscus or something else? So you shouldn't just treat the pain as, oh, this is pain, what pain meds should I give? So first, assess the patient, understand the surgery that they had, review the records, check the vital signs, obviously. check if they have a epidural catheter in place. If they have one, we can check if it's working. Is it alarming? What pain meds is the patient on? Is he taking the pain meds? So I don't want. We don't like to think of, as I mentioned earlier, pain as just a number.
Right.
What's your pain, and that's it. No, you have to think of a multi-dimensional way of managing pain, which is hard because pain is, as we said, subjective.
Yeah.
So these are the things that we should think about. And is the patient on appropriate medication to the appropriate surgery? And so these are the things that we should be thinking. And if not, then we can escalate either by, as we said, multimodal, Panadol, non-steroidals, if there's no contraindications, and then weak or strong opioids should be given.
Right.
And I always encourage people to say, well, for example, if they're going to give morphine, you don't just say morphine SOS or morphine PRN.
Right.
Morphine every 4 hours PRN. Like,
how come,
have a time and
what's the difference between saying, every 4, like setting that?
Yeah, because a lot of times they say, I get calls and I say, what is the patient on? And they say, oh, the patient is on, for example, morphine or oxycodone on SOS.
Right.
What does that mean?
Right.
Is it every hour? Is it every 3 hours? Is it oral? Is it IV?
Yeah.
So they have to be very specific because we need to calculate the whole 24-hour requirements before escalating, changing anything else.
Right. Okay. Interesting. I remember actually when you said calculate, I got a flashback to med school and opioid conversion calculation. So a little bit of PTSD that just shot through me there.
We also have those PTSDs. Yeah.
And speaking of pain is a number, give me your honest opinion on this. Does the pain rating question actually work?
It doesn't work on its own.
Okay,
no,
see that. There we go.
Yeah, because I've seen patients say, and it's also how do you ask the question? What's your pain 0 out of 10? That you have to be very specific. What's your pain?
They get mad at me. A few
10.
patients have gotten mad at me. They go,
yeah, I don't know.
What do you mean?
Yeah. So I'd say, and 0, no pain whatsoever, and 10 is a pain that probably brings you back to emergency. Even then, it's difficult to say it. So because someone's 10 out of 10 pain, and he's talking to you comfortably, not coming to the emergency.
Yeah, that's what I mean.
Someone else is like 4 out of 10 pain, and he's in the ER with a lot of pain. So it's very subjective. It's better to use multiple tools.
Yep.
And history taking and physical exam is vital.
And note taking wise, let's say a patient, like you said, patient is really relaxed in bed, they're smiling, they're eating, and you tell them, so how's the pain? And they go, oh my God, 10 out of 10, oh my.
I see a lot of junior frustration there.
Yeah, so what do you type down? Because I don't want to lie and say.
Yeah, you can just say what it said. Patient complaining of pain, so that's what I said. It's important to ask the patient, are you in pain? And then check the functionality.
Right.
Are they walking out of bed?
Okay.
Because you want to decanalize everything. You want to remove the IV, you want to remove the folic acid, you want to send them home. So are they moving out of bed? Are they walking? Are they eating? So that's very important.
How are they doing?
Are they coughing? Because managing pain is, people think managing pain is just related to surgery. Managing pain decreases risk of MI post-operatively, decreases risk of pneumonia from splinting post-operatively, decreases the risk of psychiatric sequelae, so PTSD, depression, anxiety from further surgeries. And finally, poorly managed pain is an increased risk for chronic pain. Okay, so what do you write? You write that patient says he's in pain, let's say 5 out of 10, but is able to feed, eat, walk, and so on.
And so it's just context. That's the key.
Yeah, and if they're not bothering, like they're not constantly asking for pain meds.
Yeah.
Then you take it as it is. Yeah.
And with all honesty, do you still use Socrates?
I still do Socrates, honestly. Yeah, no, I'm not joking. I still forget sometimes. Yeah, so it's site, onset, radiation. Yeah.
It's such. I used to love in med school whenever I had an endoscopy, the pain station.
Yeah.
I used to get so happy because I'd sit back, I just go, oh.
Yeah, just like
sight, onset.
Yeah. No, it's still good.
Yeah.
Still good. Actually, I'm surprised when I ask someone and they don't say Socrates. Like I'm like, oh.
It's an amazing mnemonic. I love it. Okay, so next part about juniors and anesthesia.
Correct. Yes.
consulting anesthesia.
Mm-hmm. Okay.
So, do you think that a difficult cannula is a valid reason to consult? I know you guys are probably better, but do you think it's a valid consult?
I think depending on the context, it could potentially be a valid consult. I think there are some skills that all doctors, regarding of specialties, should have, such as IV insertion, nasogastric insertion, and so on. These are some skills that all doctors should have, and consulting anesthesia for them, and it happens worldwide, it's not just in Kuwait. To insert them is not always valid.
Yeah.
It has to go through a process.
Yeah.
The nursing team have tried, the junior has tried. Ideally, the senior should have tried. The problem is, I'm being frank, we live in a society, in a medical society where the seniors don't have experience, more than the nursing, for example.
Yeah.
So they feel like, oh, well, why do you call me? Just call anesthesia.
Yeah.
Because, so if you want to change something, we should work on changing it. So,
Right.
so for now, I understand when they consult us. Yes, I'm a bit frustrated because no one else tried.
Yeah.
But sometimes that's just a waste of time, or they're just going to poke the patient for no reason.
A
So what
waste
we
of
should-
resources.
Yeah. So what we should do, and some doctors try to do that, is create a boot camp, for example.
Oh, okay.
IV nursings with anesthesiologists, and they would round on the floors, teach residents, teach even seniors how to insert IVs, what's the technique, practice. Then these people would graduate from this boot camp, and no need to call anesthesia.
And they can train other people.
Train other people,
Yeah,
and
yeah.
it carries on. And I'll give you an example. Name dropping again. So I worked with an endocrine surgeon, Dr. Salman Safran, excellent guy. He finished from Ireland, went to the US, came back, and we worked together a lot in Jabr and other hospitals. Every time in the OR, he comes in and says, "Oh, you're gonna put an IV? I'm gonna do the IV." He takes in the hand, and I'm so frustrated because I barely get. I work with a lot of juniors, so they want to do a lot of stuff.
Yeah.
He's like, no, I want to do it. And then he puts a 14 gauge comfortably. And then when I asked him how, he said, when I was in Ireland, we did that boot camp thing.
Right.
And it just lived with him. And he's a consultant surgeon, doesn't need to do that, but he enjoys doing it. Yeah.
Right. I mean, that must be a very useful skill. I notice here in Kuwait, the juniors don't do even cannulas, normal.
Yeah, which is a skill that will serve them well.
Yeah, I mean, it was hammered in for us in med school in the UK, but here it's
sad
not
to
expected
drop
of
off.
us.
So yes, consulting sometimes is very valid, but the right thing to do is for us to, instead of just saying don't call us.
Yeah.
Okay, well, how about we change the culture?
Right.
Yeah.
True.
Yeah.
And more on consults. What do you want to see in a consult when someone's consulting you? Because for me, when I've written consults before, I followed a lot of the format that I did in the UK, but I've heard a lot of mixed advice. On one hand, I've heard keep it short, brief, they don't have time. And on the other hand, no, write everything. And I've also been frustrated with, I write a big consult, took me half an hour to write, and then I get a phone call right when I'm clocking out saying, hey, can you tell me everything that you just wrote?
Okay.
Yeah.
So, I'm going to be honest, I might be wrong, I don't know, but I don't think any consult should take 30 minutes to write.
Okay.
There should be a question, and like a lot of times I get a consult and it's a history taking.
Right.
Like the patient just mentioned what the patient has,
Okay.
but there's no question. Like,
Okay.
what's the exact question? That's the most important thing.
What's the exact question?
Yeah, we can go and take. I think what you're trying to say is that there's mix. Some people just want a short question, and some people want the whole.
They
thing
want the
given to them.
context. Yeah.
Yeah. So I think the question, briefly, while summarizing what the patient has, without necessarily giving the whole past medical history. That's my job.
Okay.
To go and take the past medical history, past surgical history, and so on.
Right.
And then formulate a plan.
Okay. See,
So-
that's useful to know.
Yeah, that's what I think. What a consult should be. A consult should be a question that's direct and appropriately. Yeah.
So focusing mostly on the question.
Mostly on the question, with mentioning important aspects that are related to the consult.
Okay.
Not necessarily the whole history.
The whole, okay. So focus history.
Yes.
And now another issue that we have as juniors. We spoke about this briefly before starting the podcast.
Yes. Yeah.
The rushing issue. So for our viewers out there, this is a very common situation you're going to have. Let's say you're in internal medicine and your patient needs a colonoscopy and they need anesthesia clearance. This is the worst thing that could ever happen because you're in the middle as a junior internist.
You give me a lot of flashbacks.
You have to sync up between internal medicine because they're rounding or whatever. Then you need to sync up with gastro because they're doing the colonoscopy. And then you need to sync up with anesthesia. The issue that I've found specifically with anesthesia working has been there's been pressure on both ends where anesthesia is obviously like over. I appreciate they have a huge list and they're busy. And then on the other hand, we have the internist saying, get this patient to the colonoscopy so they can be discharged so they don't get a hospital-acquired infection. And then you're in the middle. What's your advice?
Okay, so I remember as a junior, we used to literally harass the radiologist to go to the radiologist. What's the results? What are the results? We want to make a plan, and they're like, I'm trying to read this.
Yeah.
Or because we're pressured by whoever we're working with to have everything ready by the afternoon.
Yeah.
So I think it's frustrating because there's no it's not a loop. It's not going full circle.
Yes.
It's fragmented.
Yeah.
And you mentioned a very important point, and all specialties, including anesthesia, have a very busy schedule.
Yes.
One of the main reasons is that we see not almost every patient going for surgery or colonoscopy is currently being seen by anesthesia and being investigated by anesthesia.
Yep.
So blood count, CBC, despite the updated guidelines to not do that. So ideally we don't need to see every patient before surgery. For example, I'm pretty sure you're a pretty healthy guy. We would call you an ACA1, which is an American Society Anesthesia Scoring.
Yeah.
For people who are completely healthy. These patients do not need to be seen prior to surgery, and more importantly, do not need to have investigations done. So currently, if you do that, the colonoscopy will be cancelled. Just FYI. Yeah, if you don't let the anesthesia see the patient and do the investigation. But what we are trying to do at the anesthesia council level is come up with a new plan, updated one, whereby patients who are healthy for elective procedures, even urgent procedures that are minor or not necessarily critical, do not need to be seen by anesthesia prior hand and according to the guidelines and go ahead with the surgery. So that will help a lot. That will take at least, I'm guessing, 30-40% of the
Just
work.
reduce the patient burden
Just
that way.
reduce the burden, but that's not happening now. For now, you might have to just go through this labor-intensive process.
So that will bother.
I'll do my best in my hospital to make sure they listen to you guys.
Now, tell us what's your biggest pet peeve consult?
What's that?
Like something that just annoys you. You do not like getting this consult because you're like, I don't need to see this.
Let me think. Two things. One thing, it's not. I think in Kuwait it's valid.
Yeah.
Which is a central line consult. I don't like to see it because I feel with the resources we have, with the ultrasound resources, we should have created something like the boot, and with the internal medicine residents and other residents, including surgical residents, rotating in the intensive care unit,
right,
and seeing central lines being put in, and actually putting some central lines, that they should be confident enough to put central lines on the floor.
Right. Okay.
I've worked with a medical student that's completely surprised. She had so much experience in POCUS.
Yeah.
Already as part of her training, she knew more about the ultrasound than I did at her level. So the generation is completely changing.
Definitely. A lot of my colleagues were obsessed with POCUS during my internal medicine time.
Yeah. So
I heard POCUS and you just see them like they're running. They're like, where?
And she can visualize the heart, put in an arterial line with the ultrasound guided. That took me like 3 years during residency to master.
Wow.
And she's doing it as a medical student.
Wow.
And many other people like her. I know someone also as a assistant registrar level who was teaching during the ICU conference just recently, teaching doctors like senior doctors, how to progress. So
that must be an ego boost for the assistant.
yes, he's going abroad to study medicine. But anyway, so we have the resources.
Mm-hmm.
So I get frustrated because I feel like everyone should learn the skill,
right,
and use the utilities we have. So
right.
That's the main one that I get I get sad because I feel we fail ourselves,
right,
like, as anesthesiologists and other specialties.
Mm-hmm. Okay, so that would be your main.
And just like because I'm gonna go do it.
Yeah, yeah.
The question asked.
If it's not you, who?
Who else?
Yeah. Perfect. Awesome. That's pretty much everything that I wanted to discuss with you today. Yeah. You've been an amazing guest.
No, you're amazing. I honestly, I think this shows a great idea.
Thank you so much.
I hope it continues, and I'm sure it will.
Yeah.
And just keep the coffee pouring.
Is
that what you say? I don't know.
Yeah, no, I love that.
Party or
we're gonna seal that.
Okay,
we're gonna seal that. That's gonna keep the coffee pouring.
Yeah.
I'm gonna tag that at the end of the episodes. I love that. I love that. Thank you so much. You've really opened my eyes to anesthesia, because for me, before coming in, I didn't want to tell you this, of course. Anesthesia was the guy that's kind of waiting at the besides the surgery, just waiting for you know,
just behind the curtain.
Cannulas. But you've definitely changed my perspective.
It's far from the truth, and if one person listens to this podcast and decides to join anesthesia, I'll be happy. Yeah.
I mean, I know for a fact that you guys are geniuses. I always knew that because of physiology. That was, always already done. But I really appreciated the impact on quality of life of patient that you guys are doing.
Thank you for giving me the time.
Great work.
To collaborate. Appreciate it.
Awesome. So that's the last sip of coffee for the day, everyone. A last very special thank you to our guest, and please be sure to tune into the Doctor's Brew next time. Hope you enjoyed. Thanks. Hope you all enjoyed this episode of the Doctor's Brew. New episodes to listen to with a cup of coffee coming your way every Sunday on YouTube and Spotify. And be sure to follow us on Instagram for all the latest updates. See you next time.